So I thought I'd, it's a bad photo of me. My children say, Mum, you can't show that, it's terrible. But so I'll share some personal stories. So, you know, as a Māori academic, you know, I'm on the lower end of the deprivation scale, but still for a Māori in the lowest deprivation, we have the same life expectancy on average as the Pākehā, the most deprived. So a colleague said to me recently, so I'm nearly 50, and so was my colleague. She said, I've never had anybody die who I've been close to, and I was like, really? You know, I've just been to 3 tangi and amongst all Māori men in their 50s. And so for any Māori, you know, that's just shocking that you could not live to be 50 and be 50. So yeah, I mean, I've nursed my dad. My mum nearly died when she was 60 because of poor care after an MI. I've lost cousins in their 40s. I've lost an uncle to racism. That's a long story, but anyway. And I could go on, but I think we've all got those stories, and that's, you know, what drives us. Oops, I won't end the show. So this is what Andrew said. I wrote it down. To help you be transformative change agents. This is just part of what we've been working on. So this is the main thing I want to talk about today. And we call it the He Pikinga Waiora implementation framework. So Rob talked about the fact that unless we do something and do something differently, we're not going to reduce inequities. We want to reach that 25% reduction in inequities by 2025, but I want to exceed it. And I want to get there before 2025, quite bloody frankly. And, you know, I can't do that by myself. All the Māori researchers, Māori politicians, Māori health professionals, Māori health workers, Māori community workers can't do it. It's up to all of us. And as research leaders, it's up to you guys. You know, you are our future. We're really hoping that you can help us with this. John said we needed the political will, and quite clearly we need a hell of a lot more political will than what we've got currently. So we need to develop and implement interventions for Māori and others who bear the burden of health inequities, and so that includes our Pacific cousins. We need to get over it's not my jobism, which is what we've got in health. So, you know, I always say if you get a kid who goes to hospital with 2 broken arms, you get the first arm fixed and then you get an appointment in the mail for fixing the other arm. It's not that bad. It's not that bad. We don't fix the fact that the kid's parents smoke, that they live in a shitty house, you know, that they're not enrolled with a GP, that we just kind of miss that kind of stuff. So let's just quickly move through this. I mean, this is like teaching your grandmother how to suck kumara, because you guys know this stuff, so excuse me. We know that a lot of it, we know that we want to achieve equity as a result of any intervention we do, and that needs to be a priority, and we need to measure progress towards that, meeting that goal. But we also know that any intervention runs a very high risk of increasing inequities, because, you know, here's the gap. It improves health for non-Māori, non-Pacific really well. It improves health for Māori a little bit. The gap's increased. So we don't want to do that. We want to go here and then. So we come up with this Māori implementation science kaupapa. And I'll quickly whiz along because I think we're running a little bit behind time. So we centred our framework on kaupapa Māori. So all these 4 elements have these 4 elements: systems thinking. So you can think of community engagement and cultural centredness as being about community focus. The systems thinking obviously is about big picture helicopter views, thinking about all the different levels and how things link together. And the integrated knowledge transfer is how do you make things work on the ground. So that's, but we started with the kaupapa Māori at the core. And all of these elements have really strong conceptual fit with Copal Marty. So Andrew talked about, the conflict, what did he say? About being a disruptor and, all of that kind of stuff, and protesting. We've all started off as protesters at some stage of our careers. And Inu Pōmari, he was one of those Māori men who we lost in his 50s, or, he managed to work behind the scenes, and he was an elegant gentleman. So there's that notion of resistance and challenge, and tikanga and mātauranga, and also about relationships. Community participation and control is central. And there's this whole, we've got all these grand ideas, but there's also this thing about practicing what you preach and actually being tika. I don't really like this name cultural connectedness, because I don't think it's about culture. It's not about learning Māori culture or anybody else's culture. This is about community connectedness to me. So in the ideal world, we can't let the community define every problem, because they're not all academics, but we can provide them with the tools so they can at least have a say. And in developing the solution, obviously. And reflexivity, it's all about that power and privilege and kind of doing something about that, not ignoring it. And leaving the community with something valuable that's going to make a difference for them. So we aim for shared leadership and this social justice kind of thing. We're weaving that in quite strongly. And shared decision making and building capacity of the communities and the researchers. So this is kind of new for me, because I'm like a cancer geeky kind of political kind of person. And I have relationships with Māori communities, but not usually doing research things. So it's building my capacity massively, and I'm really loving all the learning that's happening for me out of this. It's fantastic. Systems thinking, as public health physicians, there's a lot of you in the room, we like little helicopters. We like to have a big picture view and look at all the patterns and all that kind of stuff, and see how things link in, and feedback loops and all that kind of stuff. Time delays. And then integrating knowledge transfer. I think a lot of us do this intuitively when we do a project. It's like, okay, we want to do something that the nurses are going to do. Let's invite a nurse to the meeting at the end of the project just so you can do it. But it's about actually, if you're going to have a nurse-led intervention, then they need to kind of be involved right from the beginning. And same with a community intervention. And I know it's all very intuitive, but yeah. So John Etzel, who's from the States, he did a lot of the work around, he's a community-based participatory research professor, and he did a lot of the work around the literature search, developing the framework. We all kind of argued over that for a long time, and then we developed up a coding scheme and applied it to 13 studies, and it seemed to explain differences in diabetes outcomes and blood pressure outcomes, which was quite pleasing, even though it was only 13 studies. So we want to test run it in many different situations, but I'm hoping you guys can help us with that. So it's in publication. Yeah, and it, we think it holds promise. So even before, while we were coding it, we test drove it in a few different areas, and obviously with the AAA screening program, it wasn't pure community co-design, because the community didn't come to us and say, hey, we want a AAA screening program. Well, they kind of did, actually, because they had some deaths. But so our project funding started in March anyway. We've done systems mapping, literature search of interventions that work. We've engaged with Te Koho Health and Potiri Trust, two Māori community providers, a sector working group. We've linked our communities. We've provided them with funding so they can employ community researchers. We've linked them with Health Tap, which is, they market themselves as the world's first global health provider. How about that? So that's all kind of like virtual health. We've linked them with a professor of gamification, which is pretty cool if you want to be a professor in something. With the Virtual Health Information Network, and they're doing an IDI project around parameters from pre-diabetes to diabetes, all of that kind of stuff. And now the community's developing their intervention using the framework, the literature search, the systems map, and all the relationships that we've hooked them up with. And our goal of reflexivities works so well. You know, we are their pet, we're the community's pet researchers. And they said to me, one of the community members said to me, oh yeah, we're having a meeting tomorrow to discuss our intervention. And I'm like, oh, can I come? I didn't get invited in the end, but hopefully they'll invite me to the next one. But yeah, so it's working very well. So yeah, we've got, this is hot off the press, our little framework. So that kind of explains all about it on the front page, and then there's the framework at the back, and it kind of, that's the variable, and then it tells you how to do gold standard best practice, and then it tells you what really bad practice is. So you can kind of fit different projects into that. And because we're practicing what we're preaching, please, if you find any typos or if you think that could be improved on, please let us know and we'll change it. And we also want to know how you use it and how you find it. Hopefully it'll be a lot of fun and you'll really love it. Yeah. It's kind of gone viral before, so we just printed them like this yesterday, So that's our first kind of decent copy, but it's already kind of taken off, and we've got people who want to distribute it in the States and in the UK already, so that's quite cool. But I thought, you know, let's do New Zealand first, and I think it's a good little tool. Thank you.